there's other cases we could present, but honestly, I'm trying to present cases that kind of have a story within the medical story. And again, we are seeing 45-year-old people with clots. That's kind of my point. That was not something we'd see all the time outside of. I mean, not many people have atrial fibrillation in their 40s. So that's what I'm trying to get at. So this patient was kind of inherited in my practice. Our senior partner recently retired not too long ago, so I was starting to get some of his patients in as well. So 3 years prior to that, so he was in his younger 40s, obviously. He had an embolus, which was a hypercoagulable embolus. This was not atrial fibrillation. And to his proximal left SFA. So at 3 years ago, the 40-something years old, healthy guy, you just bring him to the OR, right? Do a very straightforward open embolectomy with a left common femoral artery cut down, one or two passes with a Fogarty, got the clot out of there, right? Obviously on anticoagulation, following him up, every 6 months to a year. Of course, he's healthy. He has a full-time job. He's very thin. He's not obese at all. So he's doing great, right? His baseline ABIs were about 0.6. I mean, although another thing about open embolectomy, I think Bruce could tell you, you could throw Fogarty's down all day long. You're never going to get all the clot out. You always lose a tibial out of it or two tibials instead of, so as long as you have one tibial of flow, that's really what you're shooting for in these kind of scenarios. So he had baseline ABI about 0.6, but one day he comes in and he's like, hey man, I got pain in my left calf. Now, granted, he's very nervous, right? He's anxious for 3 years now. He's worried that he keeps on throwing clot, right? So it's almost like a crying wolf kind of scenario with him. So I'm like, yeah, man, you've been 0.6. You're 0.6 today. You're sure you really have pain? It's like, yeah, his foot's not really cold. Obviously I don't have as good pulses at this time. So I order an arterial ultrasound, and that arterial ultrasound does show a reocclusion of the proximal SFA, right? But he's ambulating, he's walking into clinic, but you can't have a reoccluded SFA, and you got to do something about that, right? So here I am looking at this guy in our clinic. This is a very real scenario. And I'm like, what do I do? It's not really emergent, not really elective, right? It's kind of semi, if you will. He doesn't want to go into the hospitals because of COVID. That's another reality, right, of these patients. That's why, I don't want to have more clots because COVID's causing clots, right? So we have an outpatient lab. And I'm like, you know what? I might be able to do this now, never before, in an outpatient lab setting because I know his history. I know what he has. There's not chronic atherosclerotic disease, right? So we do that. I think of 2 or 3 days later, I can't remember the exact timing, but so we do a standard left lower extremity angiogram from a right femoral approach. When you really get a good look at it, you can see the thrombus sitting there right at the proximal SFA. So we get the 7 French sheath up and over, put the trumpet in the distal common femoral artery, deploy the baskets right below the clot, one pass. You know what I mean? Look at I think the next slide should probably have the organized clot in it. I'm assuming we should have that, or we don't. But one pass, organized clot is gone. You can do one thing I did notice here. You do get a little spasm right here. You may have some residual hyperplastic disease. We did perform balloon angioplasty after. I did take that clot out of the profunda. I just didn't show it. So one pass in the profunda as well. And you get this organized clot, right? And then this probably took us, honestly, when we started, 15 minutes or so. Like, you shoot your angiogram and you do 2 passes in 10, 15 minutes, outpatient setting, and then the guy literally goes home that day, and then he's actually been doing fine ever since. So I think that's pretty much it for this case. It was more of a, how is this changing what we're doing? How are we approaching this? How are we keeping people out of the operating room, kind of long term? Basically, we have another tool in our arsenal now, even in an outpatient setting.
Great case, really interesting. I think one of the things I'm getting is how, and I'm really, really pleased, is that how confident you guys are in the results using this device. I mean, that's not what we had with the aspiration devices before. I mean, you went in going, oh, I hope I get it all. I know I might not get the organized, and then you're always running those scenarios in your head. But to have the confidence to take this to an outpatient lab, I mean, that really tells so much.
Hey, Gary, can you go back 2 slides?
2 slides, got it. Yep.
So look at the information that you have on the markers on the baskets. So your proximal basket is opened up more than your distal basket in regards to the markers. So that's either it's embedded in some clot or that's just a smaller artery. And watching the markers on the baskets is really helpful. So then if you go to the next slide and look at the arteriogram and see the stenosis there, your baskets mimic the underlying artery, and that's really helpful to then know that you got something more there that's taking up volume and space, that's not soft, it's firm. And that's just an excellent example, and I can see why you'd end up wanting to balloon it. And the markers actually predicted that at the time with the basket delivery and traversal and retrieval. That's really, really helpful thing.
Yeah, it's a really teach you point, because Joe, you're too young for this, but there was a radiologist in Chicago that used to take all these cases and give, I might remember since because he's old like me, but he used to give these people 1, 2, 3 days of thrombolytic therapy and reduce these really long CTOs to these little atherosclerotic stenoses. And he'd say, see, you don't have to treat the whole thing. You just have to treat a little bit. Then we all went home and tried it, and they all bled and had complications. We went, I'm not doing that anymore. But this shows you, and I think Bruce's point is absolutely right on, that where you get compression of the baskets, it's usually something like an atheroma stenosis there that you know you're probably going to have to go after, and it's something to look for, because then you can predict that you're going to balloon angioplasty that or something along those lines.
Yeah, absolutely. There was thrombus in that area, twice in that guy's life. So he definitely has hyperplastic area intima in that area. So the interesting thing I wanted to also mention here is that now that we're becoming more confident that we're taking out the organized clot as well, prior to not being as confident because there was no other devices, what that saved him is actually a stent. So I don't mind putting in stents. We put in stents, but we really don't like to put in stents in the SFA because of the restenosis rate. So when you're getting confident that you're getting all the organized thrombus out, then you just do an angioplasty, and if you get a good result, then you move along, right? You're in the past, you really didn't know you got all the thrombus out, so you better put a covered stent right there. That's what I'm trying to say. To avoid it. So you're avoiding another complication down the road. That's what I'm trying to get at.